All right, so part 2, we're going to talk about the chronic conditions dealing with diabetes mellitus. And so we're starting with the 3 polys, the 3 Ps of diabetes, which is polyuria, polydipsia, and polyphagia. Before we actually get into it, just the word chronic here means that these are long-lasting symptoms or complications, but they're not as severe. So acute symptoms are going to be short, sudden, and very serious. But chronic is something that you have, like if you think about chronic pain, it's like not intense enough to, completely take all your attention, but it's always present at low levels. So polyuria means having more urine, right? So increased urine production. And this is a direct result of hyperglycemia. And this is that osmotic component to glucose. Polydipsia is going to be increased thirst because, of course, you're losing water through the urine. So you're always going to be thirsty. And then polyphagia is that you're always hungry because of that low insulin level. Your body thinks it's starving. So if your body's cells cannot take up the glucose, your body is going to act like it's starving, and one of those things is to trigger hunger. Okay, so polyuria, polydipsia, and polyphagia, the 3 Ps, or the 3 polys. Other chronic complications, we'll start with glycosylation. So in your outline, I have number 1, which is this limits your cell activity because they're lacking their primary resource. So again, I wanted to bring you to this table again and just remind you that your cells, different cells of the body have different behaviors when it comes to glucose uptake and whether or not they need insulin and whether or not they need the affinity, right? So we know that some cells, like the pancreas itself, the liver, and small intestine here, their receptors have a low affinity for glucose. So we actually need a fairly high amount of glucose in order for those organs to take up glucose. And then other things like your skeletal muscle and adipose and the heart actually depend entirely on glucose. So they need entirely on insulin. So they're insulin dependent. So depending on the activity of the transporter that's used on the organs will have different effects with hyperglycemia or with low insulin. But overall, right, if they can't use insulin or if they're insulin dependent, for example, then their activities will go down, right? So you're going to have less energy production, less ATP production because glucose is not being utilized in those cells. The second one here is really interesting. So here's the 3 Ps, before we move on. This is just a flow chart of the 3 Ps. I probably don't need to go over it with you guys, but diabetes, low insulin, and so the plasma will have high glucose. When you have high glucose, and we'll talk about this again, you're going to get a lot of glucose filtered out. Remember that the Bowman's capsule, right, all 100% of the glucose is filtered out. And then you need to reabsorb all of that glucose in the PCT. When you cannot reabsorb all of that glucose, then you're going to have glucose in the filtrate. And that's going to change the osmotic pressure. And it's also going to draw out more water into the filtrate. So it's going to increase your filtration rate, glomerular filtration rate. That's going to lead to extra water in your urine, which is polyuria. Okay, because you're losing this water, you're going to have decreased blood volume. This is going to lower your blood pressure, and your body's going to respond by triggering, the RAS system, by triggering your sympathetic division, the nervous system, and it's also going to trigger thirst. So that's your polydipsia, and then your hunger is separate, but it's going to work on the hypothalamus. So those are 3 Ps. And let's move on to glycosylation. So turns out that when you have glucose in very high concentrations in your body, it attaches to random proteins. And this is called glycosylation. There's no enzyme required for this. So it's non-enzymatic addition of glucose to proteins to form what's called advanced glycosylation end products, or AGE. And this is a picture of hemoglobin becoming glycosylated, or glycohemoglobin. Now, hemoglobin is actually a glycosylated form of hemoglobin is actually detectable with a simple blood draw, right? So this is a protein that's not complicated. We can take it out of the body. We can check to see if there's glycosylation. So this glycohemoglobin is called HbA1c. And since your red blood cells last in your body for about 60 days, right? Then if you have a blood draw, the blood that you have there is going to be something that's been in your body for about 3 months. So you can actually look at sort of a long-term, you can see whether a person's had elevated high glucose levels for quite a long time. So this blood test can measure the amount of glycosylated hemoglobin, right? And they can get this average over your 2 to 3 month span before the test. And you can sort of get an average blood glucose level by the amount of glycosylated hemoglobin. One thing about the AGEs that are formed, these glycosylated proteins, is that it's reversible. So once your glucose levels goes down, it can come off, right? So that's good news. Another example of a glycosylated protein is fibronectin. So this is just a really busy picture, I know, but I just want to point out that healthy wounds and diabetic wounds heal differently. And fibronectin, which is actually not on this picture, but it doesn't matter. I just wanted to show you that there's a difference in healing. And fibronectin is one of these proteins that are involved in the healing pathway in creating the connective tissue scaffolding. And when it's glycosylated, it's compromised. It doesn't work as well. And so it's going to slow down and compromise wound healing, which is why diabetics have issues with healing the wounds. Okay, so let's look at the polyol. So that was glycosylation. So you'll find, or if you read more about diabetes, this glycosylation causes a lot of problems. And you can think about just throughout the whole body, right? You have proteins everywhere, enzymes and structural proteins. And if they're glycosylated, this is an abnormal form for that protein and it can cause issues in different organs. Number 3 in the chronic complications is something called the Polyol Pathway. And so it turns out that when you have really high levels of glucose in your body, it comes into your cells. And normally, right, let's talk about the normal pathway. Normally we go, oh, okay, glucose comes in. It's going to undergo glycolysis. And then after glycolysis, it enters the Krebs cycle. And after Krebs, it goes to the electron transport chain. And that makes ATP, right? And you get out of that CO2 plus H2O. Those are waste products. So this is our cellular respiration pathway. Well, it turns out that the enzyme that's responsible for initiating that first step in glycolysis is called hexokinase. Okay, and hexokinase has a really high affinity for glucose. So when glucose comes in the cell, hexokinase grabs it and it's going to enter into glycolysis, and then we can get rid of glucose that way. However, when you have really, really high levels of glucose inside the cell, there's another enzyme that's in specific cells like the retina, the lens, the cornea, the kidney, the Schwann cells, and the endothelium of your blood vessels. This enzyme is called aldose reductase. Okay. This enzyme also works on glucose. It changes glucose to its alcohol form, the polyol form called sorbitol. And sorbitol is changed again to sorbitol hydrogenase. So this is a normal process that the cells that I just mentioned, the retina, the lens, they have this pathway because it's meant to do a specific metabolic reaction. However, if you have an excess amount of glucose, you have an excess amount of sorbitol being produced. And what happens is that the sorbitol does not leave the cell because there's no transporter for sorbitol out. So it builds up inside the cell. So the concentration of sorbitol goes up, and that's going to act as an osmotic solute. And so it's going to draw water into the cells. The cells are going to swell, and then you're going to have issues with that swelling. Okay, so the polyol pathway does two things. I just mentioned one. The one thing is that we're going to have swelling of these tissues. The second thing that happens is that the polyol pathway causes a depletion in NADPH. So you see how NADPH is being used and converted to NADP. So the more aldose reductase does its job, the less you're going to get less and less of this stuff around, right? It's going to get used up. That NADPH is actually required to make an antioxidant. The antioxidant is called glutathione. And just a quick, what is an antioxidant and why are they good, is that in your body, under normal metabolic chemical reactions and normal processes, your cells are going to create things called reactive oxygen species. This is something, a reactive oxygen species is also called a free radical, and this is an unstable molecule because it's an unpaired electron. Remember, electrons come in pairs, right? 2 electrons. Remember in that the orbital shell, right? 2 electrons. Anyways, if you just had 1 electron without its buddy in that orbital shell, it doesn't like that. It's unstable, and it's going to rip an electron away from another molecule to stabilize it. The molecule it's taking the electron from is going to get damaged in the process. And so this reactive oxygen species is damaging to other molecules. It can be damaging to DNA. It can be damaging to your enzymes. So it's just a nasty thing to have around. Antioxidants will absorb these ROSs, these reactive oxygen species. So glutathione is one of those antioxidants that will minimize and sop up, right, take away those reactive oxygen species. Damage, this kind of damage due to these reactive oxygen species is called oxidative stress. So your antioxidants will minimize oxidative stress. Antioxidants, there's lots of them in your diet. You'll hear people, if you're into nutrition, there's vitamin C is an antioxidant, vitamin E is an antioxidant, like the blue pigment of blueberries, that's an antioxidant, right? So that's really good for you. So back to this pathway, what happens is that when you deplete NADPH, you are going to deplete glutathione. So you're going to, number 2 of the polyol pathway is you deplete the antioxidant. Okay, so that's the 2 negative side effects of a lot of glucose entering the polyol pathway. So here's the image from your textbook, right? So here's glucose. Glucose, this is normal blood glucose, is using hexokinase to enter into glycolysis, and glycolysis will ultimately produce ATP, or we can go ahead and build our glycogen, right? Either way, we're storing our glucose, we're using our glucose in a normal fashion. When you have hypoglycemia, right, we have our elevated glucose. Aldose reductase is taking it. It doesn't have a high affinity for it, but it's going to take it and turn it into sorbitol just because there's so much of it. And then the sorbitol can get turned into fructose. In the process, right, here's our using up NADPH to make a reduction in glutathione. And then it turns out that we actually make, and I didn't mention this previously, but we do make more this ROS, reactive oxygen species, in this process as well. So it's like a double whammy. You're taking away an antioxidant and you're actually making more ROSs, right? So that was the second thing I talked about that was bad about sorbitol. And then I'll just add here that this disrupts osmosis and you'll have swelling of those cells. Okay. When you have cells of the lens getting swollen from osmosis, it leads to cataracts. So in this area, I mentioned that you can get, if the lenses can get damaged this way and form cataracts. If you don't know what a cataract is, it's just a cloudy lens, right? So if you look in someone's pupil, you'll actually see it cloudy. And if you see older dogs out there, sometimes really old dogs will get cataracts and they have a cloudy pupil. That's what that is. So that's, now you know why diabetics sometimes get cataracts. Okay, it's because of the swelling, because of the polyol pathway. All right, next, number 4. Superoxide formation and oxidative stress. So this is piggybacking on those reactive oxygen species. This is another way we're making more reactive oxygen species. Here is our electron transport chain. When you have a buildup of glucose, well, let me start by saying, let's just review, right? So we have glycolysis, just a quick review, glycolysis. That is going to enter the Krebs cycle, okay? And remember that we are creating things called electron carriers, NADH and FADH2. Remember that they are going to drop their electrons off on the electron transport chain. And those electrons are going to travel all the way to the end. They're going to, so here's our 2 electrons. They're going to attach to the oxygen that we breathe. We're going to make water as a waste product. All the while we're making ATP through oxidative phosphorylation. Now, if there's a buildup of because you have so much sugar, you have a increase of your electron carriers, right? So what happens is these intermediate, especially coenzyme Q here, gets backed up with extra electrons. And so instead of waiting for it to be passed on down the electron transport chain in the normal fashion, they just kind of get rid of those electrons to oxygen. So you can see oxygen is going to pick up that electron, and it's going to form this guy. This is your superoxide, O2 negative. So that negative sign means that there's an electron there that is unpaired, okay, and it's going to be very reactive, and it's going to try and steal electrons from other molecules, and it's going to damage your cells. So this guy right here, the O2 negative, is called superoxide. Now, this happens normally, okay, that this binding of O2 to your electrons here is a sort of a normal function, and your mitochondria are prepared because they have an enzyme called superoxide dismutase that can break down the superoxide, right? So there is an enzyme that can take care of that, but when you have a lot, right? There's only so many enzymes to go around, and if you have a hyperglycemia, if you have a lot of blood sugar, you're creating a lot of these superoxide species. That enzyme may not clear all of them, right? So you're going to have a higher concentration of a superoxide than you normally would, and that's going to cause oxidative stress. Okay, so now you're learning how extra glucose is really kind of taxing in this oxidative stress way. All right, let's look at the next slide. So this is sort of everything together. But I didn't talk about protein kinase C yet, so let's talk about protein kinase C. Protein kinase C, so those reactive oxygen species I was just talking about, they activate a kinase. Remember what kinases are? Kinases phosphorylate other molecules, and they activate other molecules. So there's one protein kinase called protein kinase C. So here we go with hyperglycemia. We have oxidants, we have AGEs, we have reactive oxygen species, that's for oxidants. They're going to activate protein kinase C. And then obviously we're not going to go into any of this detail, but I just want to show you that this protein kinase C can activate all different kinds of cells. We're going to stick with endothelial cells, right? And you can see that it also acts on smooth muscle cells. But when you look at your outline, you see that these protein kinase C is going to be involved in vasodilation pathways of the endothelial cells. So this is here. So it's going to have an effect on blood flow, on permeability. So this is basically vasodilation. When you have vasodilation occur, right, you have a widening of the lumen, you're going to have more blood coming into that blood vessel than it normally would have, right? And that's going to produce something called shear stress. Just the fact that the fluid is pushing along the sides of that wall is going to stress that endothelial wall of the blood vessel. So if you have constant vasodilation and you have constant, basically more blood volume going through that blood vessel, you're going to have more stress on the wall. That can cause damage, okay? That's going to be called microvascular damage. And those little areas where it's damaged, those are areas that the LDL particles, remember LDL, that delivers your cholesterol, is going to find and tuck that cholesterol in those little tiny micro abrasions and those tiny little damage points. And that's where we can start to have cholesterol buildup. So we can start to see all of our sort of wrapping up, with our semester, all these different components of our body working together, or in this case, just what happens in the disease process of diabetes. Okay. So that's what's going to happen with protein kinase C. So now let's go back to our flow chart. So here's diabetes. Low insulin activity, hyperglycemia, okay? Certain cells will increase their glucose uptake. So remember, many cells don't need insulin. They can take up glucose regardless. And when they do that, okay, let's start with the one we just talked about, right? The endothelial cells. They're going to activate protein kinase C. That's going to increase vasodilation. Hyperperfusion just means more blood coming into that blood vessel. It's going to cause shear stress, and that's going to cause little tiny microvascular damages, all right? And that's going to help lead to atherosclerosis. Okay, next. Glucose uptake is increasing in other cells, mesangial cells, neurons, Schwann cells. Notice our nervous system, right? Mesangial cells, this is in the kidney. That's why neuropathy and nephropathy, they're both the kidney and the nervous system, they're both strongly involved in the symptoms of diabetics. So they're going to increase glycolysis. So this is just normal. Cells will take that glucose and try and make ATP with it through oxidative phosphorylation. However, remember, we're overloading our electron carriers in the electron transport chain, and we're making superoxide species, this reactive oxygen species, leading to oxidative stress. The polyol pathway is going to take place. It's going to decrease the amount of NADPH. This is going to decrease the amount of antioxidant that we can make, and that's going to lead to unchecked oxidative stress. We have glycosylation. We have glucose just attaching to proteins, randomly. We're going to get advanced glycosylation end products. And that's going to lead to a decrease in protein activity. Whatever protein gets glycosylated, it's not going to work as well. And then lastly, which I don't really want any detail in here, but there is another pathway called the hexoamine pathway. What it does is it downregulates transcription, so your cells are not able to make the proteins that they want to make, and that's also going to lower the protein activity. All right, so all of this damage, right, is done with this elevated blood glucose levels, which is pretty amazing, very widespread throughout the body. All right, so I'm not going to go through this table with you, but you can read it. I'm not going to ask a bunch of detail here, just to appreciate all the different organ systems and the complications that occur and some symptoms that occur, but I'm not going to ask you questions from this chart. Let's take a look at microvascular damage. All right, so for microvascular damage, we are looking at retinopathy. So this is the retina. We're looking at nephropathy. This is the kidney. And we're looking at neuropathy, the nervous system. So looking at the 70% here, right? 70% of diabetics will develop some form of neuropathy. So let's start with the retina. So all right, so what are we talking about here? We're talking about microvascular damage. We're talking about the damage to arterioles, capillaries, the very, very small blood vessels. If they feed the retina, we can imagine, right, these are neurons that are helping you see. The retina is going to be compromised. So the blood vessels are going to have damage to the blood vessels. You can have a bulge. They can make the blood vessel walls become weak, and bulge out, and that's called an aneurysm. It can lead to broken blood vessels, blocked blood vessels, and then another weird thing is that it can cause more blood vessels to grow to compensate for areas that are not getting enough blood, and all of this leads to changes in the retina where it can lead to loss of vision. So either blurry vision or just complete loss of vision and blindness. So aneurysm, abnormal blood vessel growth, hemorrhages, okay? So diabetic retinopathy. We already looked at cataracts, right? Cataracts is the swelling of those lenses. And then glaucoma is also implicated here. I'm not going to talk about glaucoma, but just know that you can have a pressure change inside the eye glaucoma can also lead to blindness, actually. That compresses the retina. Okay, so 3 complications of the eye. Diabetic nephropathy is going to be damage to the kidney, right, the nephron. And 30% of diabetics will have some form of nephropathy. And if you think about what we're talking about the microvasculature network. We're going to have dilated afferent arterioles, constricted efferent arterioles. This is going to make the glomerulus have a lot of pressure. So we're going to increase the glomerular filtration rate here, okay? And when you're increasing the vasodilation here, we're going to, over time, it's going to increase damage the capillaries here. When you start to damage the capillaries, the capillaries are going to start to let out proteins. This should not happen, right? The filtration membrane that is supposed to keep back our proteins are going to let those proteins through. And so we're going to find proteins in the urine. And the protein that we find the most of is albumin because it's the most numerous protein in the bloodstream. It's our plasma protein. And if you remember, albumin plays a role in oncotic or osmotic pressure. Again, so if we're losing proteins, guess what? We're going to also, water will follow. Okay, so we're going to also lose water that way. All right, let me just look at the notes here. Protein kinase C plays a role in this damage, increasing vasodilation here. Okay, so we're also triggering a loss of tight junctions to make the junctions between the cells even leakier so that we have a lot of filtration occurring. Okay. So interestingly, I found this out just recently, that 20% of the kidney is necessary to maintain homeostasis. So when you have this kind of kidney damage, because only 20% of your kidney is necessary to maintain homeostasis, even though you have areas of your kidney that are being damaged, as long as you have about 20% of your kidney working, you can maintain homeostasis. So you don't actually get symptoms of kidney damage unless it's really severe, right? So, so you don't really find out if you had nephropathy until the later stages. And then lastly, let's talk about neuropathy. Neuropathy is going to be damage to the nervous system. So it occurs in the peripheral nervous system, both the afferent and efferent fibers, as well as your glial cells. It will occur to both somatic as well as autonomic fibers. Okay, so both your voluntary sensation and your involuntary nerve fibers are involved. So the symptoms of nerve damage, as you can imagine, will be variable depending on where it is in your body and how severe it is. And so if you look at the sensory damage, you can get something called paresthesia, which is just an abnormal sensation. So maybe there's nothing, you can see there's nothing on your skin, but you feel tingling or you feel some kind of prickling on your skin, or it can be going numb. Dysesthesia is where you have maybe someone touching your body, but you feel it as pain. So it's normally an innocuous stimulus, but it causes very unpleasant or pain stimulus. And then the numbness. So this numbness is really implicated in this foot damage. So it's called distal sensory diabetic neuropathy. So when someone has numbness in their feet and their feet get damaged, or there's a wound in their foot, they don't feel it. And I guess it's really common in feet, and I have to look this up, but diabetic neuropathy, it's the foot is really very common for gangrene to set into a foot or a wound to develop in the foot. Maybe it's because it's something that we don't, a body part that we don't check very much. But because we have this distal sensory diabetic neuropathy, we don't get the pain sensations from the foot. And so a person will notice that their wound is not healing. The wound can get infected and gangrene can set in. So gangrene, if you don't know what gangrene is basically tissue death. So the tissue actually starts to die, turns black, and it does not return. And gangrene can spread. So if you do have gangrene, normally what they do is they amputate, or they take away the dead tissue. And if it's far enough along, they have to amputate the foot. And it turns out that this is the number one cause for lower extremity amputation in the United States, is this diabetic neuropathy. Okay, so autonomic damage would be damage to the systems, right? You can lose your reflexes, you can lose a baroreceptor reflex, you can lose cardiac autonomic neuropathy. The nervous system can come in and change the heartbeat. So lots of very dangerous, serious effects from neuropathy. What we're looking at here is diabetic cardiomyopathy. I think I'm a little bit ahead of myself. Okay, so the last thing here, progression to diabetes in the critical states, is macrovascular and diabetic cardiomyopathy. So these are the advanced stages of diabetes. We were talking about the small micro vasculature, but the damage can go to larger blood vessels like coronary arteries, and then damage to those blood vessels is secondary to atherosclerosis. And what diabetes does is a double hit to atherosclerosis. So not only does it increase your bad cholesterol, increases the LDL, but it also decreases your HDL. So as we talked about in the other chapters, this can be, this means that you can lead to heart attacks, like atherosclerosis leads to heart attacks, strokes, and peripheral artery diseases. And then for diabetic cardiomyopathy, this is where the blood vessels, the muscle, right, the cardiac muscles of the heart actually get weaker. And so that means that the contractility is reduced. And that contractility is going to affect stroke volume, right? So the stroke volume is going to go down. Stroke volume. So if you're not going to pump out as much blood with every stroke, the heart tries to compensate by enlarging. So you might get an enlarged left ventricle here. And this is, the muscle fibers have stretched, the heart chamber is enlarging, and that is dangerous. So the heart muscles get weaker over time. And compounding the dilated heart and the decreased stroke volume is the fact that the autonomic nervous system that goes to the heart may be affected with that neuropathy, and people can suffer heart attacks but not have the pain involved in the heart attack because the nervous system is compromised. And so what they end up having is something called a silent heart attack. So symptoms of a silent heart attack can be so mild they're barely noticed because there's no, that autonomic nervous system is not working. And sometimes they're just discovered accidentally. Sometimes don't even notice it. Okay. And so it's very, very dangerous. They're more common in men, but women are more likely to die from them.